we must constantly look at things in a different way.
The Healthcare Education Transformation Podcast was created by two physical therapists out of the desire to learn more about the different educational roles in physical therapy and healthcare, and how healthcare education works by talking with educational leaders and people with different perspectives within physical therapy and across interdisciplinary lines on how education can be improved to disrupt the status quo of healthcare education. This is our journey, and thanks for listening. Hello, everyone, and welcome to another episode of the Healthcare Education Transformation Podcast. My name is Brandon Powen, one of two co-hosts, and along with the other, F. Scott Fiel. And today we are talking with another dean from a medical school that is truly an innovative model that is unique to better address the needs of society. And we are so thrilled to be talking across interdisciplinary lines as we are happy to welcome Dr. Clay Johnston on the podcast today. Now, for those of you who don't know, Dr. Clay Johnston has served as the inaugural dean of the Dell Medical School at the University of Texas at Austin since March 2014. His ambitious vision includes building a world-class medical school by creating a vital, inclusive health ecosystem that supports new and innovative models of education and healthcare delivery, all with a focus on improving health and making Austin a model healthy city. He is also a neurologist specializing in stroke care and research. He is a graduate of Amherst College and Harvard Medical School, and later received a PhD in epidemiology from the University of California in Berkeley, and was a resident in neurology at UCSF, where he later trained in vascular neurology. And during his 20 years at UCSF, he rose the academic ranks to professor of neurology and epidemiology, and he directed the stroke service. And Clay has authored more than 300 publications in scientific journals and has won several national awards for his research and teaching. In particular, he has published extensively in the prevention and treatment of stroke and transient ischemic attacks, or TIAs. He is perhaps best known for his studies describing the short-term risk of stroke in patients with transient ischemic attack and identifying patients at greatest risk, and also for his work related to measuring the impact of research. Now, Dr. Johnston, thank you so much for coming on the show today to talk with us. And, I realize that you've done much more throughout your career that I've mentioned this evening, and I know I kept it pretty brief, but, was there anything that you'd like our audience to know about you that I didn't mention in this brief intro here?
Well, I think you covered more than you needed to. I would just say that for me, the journey really was, starting out as a clinician, and then getting frustrated with how little we knew as clinicians, and then getting more and more focused on research over time. And then getting frustrated that research wasn't really where the problem sat. That for one thing, the research cycles were really slow, but the other was we had produced a lot of knowledge through research that wasn't incorporated into the healthcare system, and that the real issues were how the healthcare system was organized. And so that kind of brought me through the adventure to being a dean.
Yeah, so Clay, I've got to ask, with Dell Medical School being a relatively new medical school, do you think you could give our listeners some background on how the Dell Medical School started and how you got involved in that?
Sure, yeah. So it was sort of an accident of history that UT, University of Texas at Austin, didn't have a medical school. It goes back to the 1880s in two big cities, Austin and Galveston, and they put the big university in Austin, and so they put the med school in Galveston, just to be fair. And they sort of set in motion this separation between health campuses and non-health campuses. So they had to change the rules for us to exist on a non-health campus. And Austin, in the meantime, had grown to be the largest city in the U.S. without a medical school. It wasn't the best time to start a medical school. It was at the tail end of the recession, and so they took it to the voters. In order to make the math work, they needed to raise additional funds that weren't going to come from the University of Texas, and the voters voted to increase their property tax in the Travis County, that's Austin's county, in order to start the med school. So, and that provides actually ongoing support and connects us to the community in a really interesting way. So for me, I was in San Francisco at UCSF and happy there, and one of my friends was out here in Austin and told me about what was going on and convinced me to just, at least come out and take a look. So I came out with some crazy ideas that I figured would exclude me as a candidate, but in fact, they liked my ideas and thought it would be an interesting thing to try. So that they invited me to join and start the school.
Yeah, the crazy ideas don't get you off the hook that easy, right?
No, well, I mean, I guess it depends on just how crazy. But in this case, they also realized that the current healthcare system wasn't going to work, wasn't working in Austin, and that we really needed to examine things very differently in order to come up with a better system.
That's a really interesting story. And this kind of leads into the next question, which is, for our listeners comprised of various healthcare providers who perhaps are not sure about medical education, do you think you could give our listeners some background on kind of the national average curriculum and structure of medical education and how it goes in the U.S.?
Yeah, sure. So medical school is generally 4 years. There are a few programs that are short-tracked and are 3 years and involve undergraduate training, but mostly not. You finish your undergraduate degree, and then medical school is 4 years. And they're generally organized into 2 years in the classroom, and that's often lecture-based with exams. And then 2 years doing rotations in hospitals and clinics, kind of, seeing how things actually work, and trailing docs, being part of teams, caring for patients, that kind of thing in the latter 2 years.
Yeah. So Clay, I'd like to kind of dive into some of those crazy ideas that brought you to Austin here. And could you tell us specifically with the Dell program, what is the curriculum like, and what is the model of education at Dell, and what makes it unique in terms of educational design and the opportunities for the students?
Yeah, so we started by, again, it's a wonderful opportunity to have a brand new school. So, it's really hard to make changes in existing existing med schools. There are a lot of advocates for the status quo. You have something that's working. It takes a lot more work to create something new. And people just, they get comfortable with doing it the way they've always done it. So in fact, that system of medical education that I described goes back over 100 years. This guy, Abraham Flexner, went around and visited all these med schools and worked with the American Medical Association to come up with standards for medical education. And those were the rules that all med schools have been following. So for us, though, the things have changed in the last 100 years, and it's time to recognize that. And in some ways, they've changed in the health system, and the health system has gone astray from where we might want. And by that, I mean, it's an extremely expensive system, and the outcomes are not that great, particularly when you consider how much we're spending. So overall health outcomes in the U.S. are about like in Cuba, if you look at the World Health Organization rankings. Yet we spend, $10,000 a year per person on healthcare, whereas Cuba spends $800. I mean, there's a huge difference, a huge disconnect. So, in thinking about the education, we have to think about, okay, well, how do we get here, and how do we get to someplace better? And what is the unique position of a new school in thinking differently, and then creating the education that matches it? So we really did a lot of work to think about, okay, where should healthcare go? And then that defines what the physician of the future really needs, what skill sets are important. And then that defines our curriculum. So in looking at it, one thing that's clear is that knowledge is cheap nowadays. The focus on memorization is no longer nearly as important as it was when that was a critical source of information. We have much more reliable sources at our fingertips all the time, and that's going to become more and more true as we move, from cell phones to artificial intelligence to integrated systems with our electronic health records. So there's been too much emphasis on just gaining facts. Instead, we should focus on problem solving and understanding what quality data is and what's not quality data. And then there's the whole other aspect of medicine, the communications aspect of it, understanding how health systems work in the business of medicine, human-centered design, so we can come up with creative solutions to healthcare problems, thinking about population health, so how do we keep people healthy outside of clinics and hospitals, and preventing the clinic visit, and so making it unnecessary, making unnecessary hospital visit. And so those then become critical elements in our curriculum. So the curriculum does look quite different. The students spend only a year on the basic sciences. We cheat a little bit because we take away their summer. So it's about 12 months. Most programs now are about 18 months of the basic sciences. And then they go in their second year to do their clinical rotations, and they love doing that. Makes it real. I mean, the clinical rotations include systems components to them. And then in their third year, they have innovation and leadership block, and they spend that year working on projects and also with didactics around leadership and many of the other elements that I just discussed with you. The goal is to have projects that ultimately impact health. And then their fourth year is more of a traditional year. They absolutely need that in order to decide, what specialty they want to go into. And if they do, we hope, many of them choose a primary care future, and they travel to find a good fit for residency programs.
Yeah, I think that's fantastic, Clay. I couldn't help but recognize how many parallelisms there really were with what you said within kind of the status quo of medical education, and kind of relatively similar issues there are kind of in the physical therapy realm as well. Some physical therapy programs have started, there's a couple new ones that have come out that have really started to come and really kind of come at it from an integrative model, kind of like what you guys have done at Dell to a degree, of course, and realize that's going to be profession specific, of course. But I think it's really interesting what you said at the end there. And I'm going to ask one kind of off the script here, because I don't know if I told you this, Clay, but my fiance is actually a surgical resident. She just started her first year starting in July. And she went through her whole medical school process, deciding from the steps, exams, to finding out what specialty she wanted. And what you said at the end really struck me in terms of, hopefully getting more physicians to go into primary care. And I'm curious, from your perspective, why is that currently not happening right now as it is?
Well, I think it's mostly a lifestyle decision. The reality is primary care jobs are really hard. Having to know a lot of everything, and then the pressures that have been placed on primary care docs by their employers, the number of patients they have to see, and the complexity of dealing with, calls and data coming in after hours and on weekends, and it's hard. And then the reimbursement is actually less for primary care than it is for many specialties. So the economics today are not what they should be. Our hope is that changes. If we really care about outcomes, and that's what we want to be disciplined towards. So, what we're trying to do is be completely aligned with society's interests in health. So optimizing health, which means tracking outcomes and caring about them and caring about people's health, whether they see you in clinic or not. Those are the goals that we all have as human beings, right? I mean, I do not have a goal to go to the clinic. I have zero interest in being hospitalized. I want to be as healthy as possible. So if the system is aligned with that, then I'm better off. And potentially, too, we can save some money, since we know we waste a lot of money in clinics and hospitals. And with that, though, the group that's best positioned to provide that future are the primary care docs. And we just have to figure out how to redesign their jobs so that they're more doable, gratifying, and reimburse appropriate for the level of work and anxiety associated with that job. And I should say, on the physical therapy front, a thing I didn't mention was interprofessionalism. It's a big part of our curriculum. It starts in week 1. We don't have a physical therapy program at UT right now, so we don't include you all. Know if that'll change, but that's where we are right now. But we do have physical therapists on our care teams, so we completely redesign care, and physical therapists are critical. So they're, for example, in our joint pain integrated practice unit, where we provide care for joint pain, physical therapist role is absolutely critical. The same for back pain, and they're. It's not that they're one of the important team members. It also includes social workers, and nutritionists, and primary care docs, and it happens to also include an orthopedic surgeon, at least when necessary.
Yeah, I think that's great. Especially we're seeing more and more from the more educators that we're having on, really mentioning the importance of kind of this interdisciplinary approach to education, with being able to kind of learn from other providers as well. Because I mean, even professionally, just being a clinician for a couple of years, what I've been able to pick up from some of my colleagues that work in different avenues has been very extraordinarily helpful to how I manage my patients too. So I think that's a fantastic take, and I think looks like we're definitely going to see more of that in the future. And Clay, going back to kind of Dell's program here a little bit, just because I know we were talking on the things of money before, but just from for someone who kind of wants to know, what is the cost of the program, at least from a tuition standpoint? Of course, realizing that's going to vary based on, especially the last year with interviews where they go for residency and where they're flying and stuff, but kind of seeing where the tuition cost for Dell is and how it kind of compares to the national average among med schools in the U.S. here.
So for us, the tuition and fees is $19,000 a year, and that puts us substantially lower than most public institutions with in-state tuition. So the average in the U.S. now is $34,000 per year in-state, and it's 52, something like that, out of state. So so we're cheaper. We're cheaper on purpose. It does put more pressure on us, and primarily through philanthropy, to make up the difference. But we think it's so important to take away any financial pressure to go into a more lucrative future career. I mean, still, people will make up their mind and do what they want to do, and we want to support all the decisions that can be made. But we don't want people to feel pressure from their loans, multi-year loans, to that they have to immediately go to work making as much money as possible. We want to take that away.
Yeah, I think that's a really good avenue, and I applaud you for that, because that's something that's very similarly going on in the physical therapy realm as well. With the cost of education continuing to rise nationally for PTs, and overall reimbursement going down, and therefore salaries not being as high, it's becoming much more financially straining overall, to go into to become a therapist this day and age. So I really do applaud those models and those people that are really trying to realize that we can make better providers that aren't necessary if we can help control the cost better, so they're not feeling so stressed to take those those higher paying jobs, which are probably going to be very stressful, and they may end up burning out, and these kinds of things. So I think that's really a good take there to have, Clay. I'm glad you said that. And and Clay, I recently read that Dell will lead a $15.5 million redesign of the Austin State Hospital online, which looks to be a great method to improve mental health and substance abuse care into this integrated system of comprehensive brain health. And do you think you could expand on this to tell our listeners kind of what this specifically entails?
Well, Austin State Hospital, it's been around since the 1800s, late 1800s, and some of the buildings have survived from that time. They're still used today. And, I think it's very typical for state organizations. There are now multiple state hospitals providing kind of the last resort for safety net mental health care for people who require hospitalizations. And over time, it just got run down. They never adequately funded upkeep of the buildings, and in a whole series of buildings, and so it needs to be replaced. But for us, that's not that interesting. If you just want to take the existing buildings and build new shiny versions of them, then we really haven't solved the problem. What'll happen is, 20 years from now, we'll have a new set of dilapidated buildings on the Austin State Hospital property. What we are interested in is, how do we actually change the models of care for the people in the state to reduce the need, again, for hospitalizations, including mental health hospitalizations, and to help people through the transitions, so that if they do need hospitalization, we have a gentle way to move them back into their communities. So it's really an entire care redesign. It's not just a physical plant redesign. Physical plant will be part of it. But, we're looking at, okay, well, what can we do in communities? Can we send people out to meet with the mentally ill who are homeless and high risk for further hospitalizations to reduce their risk of coming back in? And so it's really a wonderful project. long overdue for American mental health care, and we're thrilled to be playing a part in it.
Yeah, Clay, that's actually a perfect segue to my next question. But what are some other changes that Dell's looking to make to continue to provide great education to their students for improved patient care and really to improve community health?
We're constantly evaluating our education and making changes as we go. So we're really data driven. We believe that that's the way healthcare should be provided, education should work, and obviously research has known that it needs to be data driven for a long time. And so, we're constantly changing what we do in the curriculum, and it's improving, and it will continue to evolve as healthcare itself evolves. And then, in terms of community health, that is a big emphasis for us. The key is to recognize that we can take resources that are currently wasted in hospitals and clinics, and also when we consider the impact of disease on things like productivity of individuals, that interventions in the community can actually save society money. Not all are that way. Some cost money but produce health and therefore are worthwhile. But more and more, there are cost savings interventions. And, countries like Cuba have figured that out. That's how they can do it on such a low budget. So we're really interested in creating demonstrations for how those models can work. We're starting to do that in some very specific areas, and we'll accelerate that over the next couple of years.
Nice. And that'll be really exciting kind of to see how that develops. And, as that gains ground, hopefully more medical programs and stuff will kind of take note of that. And, my next question is going to kind of vary a little bit because I know this is something that a couple other medical educators that we have talked with, when we talked with Bill Jeffries not too long ago, who is the dean at University of Vermont, because we had him on to talk about how their no lecture medical curriculum is. But one thing he talked about that he thinks should be the big change is, changing the STEP exam in terms of making it pass-fail rather than have so much weight on it for residency acceptance, because he was worried that at the last year, students aren't really putting as much time into their curriculum because they're worried about preparing for interviews, studying for their exams to get the optimal residency placement so that they can, go forward from there. And I guess my question is, what does Dell do to help their students with preparing for the STEP exams and residency selection?
Yeah, well, this is one of my issues as well. I mean, I agree completely that the STEP exam is really unfortunate that people use those scores. I mean, they really don't tell us anything about who's going to be, or very, very little about who's going to be a good physician. And our current system for residency selection is really misguided. It's not going to. It's going to pick the book nerds and not the humanistic physicians, not necessarily even good problem solvers. And I think that's a mistake. Even so, our students do have to pass, and so we do help them, but honestly, our curriculum is not very focused on the STEP exam. We do have exams that they take along the way that act as practice for the STEP, and then they can, if they do well on that, they can, they know which areas they don't need to study as much, and if they don't do well, they can focus on those. But we don't believe it makes sense to focus on the kind of book knowledge that traditionally has been overemphasized in medical education.
Yeah, Clay, I'm going to kind of change directions a little bit here. I'm curious, what are some aspects that you feel really need to be addressed in medical school education in order to best prepare these new students for becoming physicians in today's day and age?
Definitely, the students are going to need to be comfortable with data. How do you identify good data? Whether it's from an exam or history or from the literature, and then how do you factor that in and use it to solve problems? I mean, physicians have been doing that for forever, but it's going to be even more important as more and more data become available in the future. And artificial intelligence is going to change the importance of routine holding on to information and more algorithmic medical care. That's going to not be in the hands of physicians anymore, and more complex problem solving is likely to stay there, and that's, I think, appropriate. The communication skills, leadership, those things are going to be even more important in the future. And think about the systems of care and all that, and creativity, also really important if we're going to have folks that can not just be subject to, and victims of the healthcare system, but can rise up and find the solutions for the patients and also for practitioners to make the profession more enjoyable and gratifying.
No, I love that, Clay. And, we kind of face something similarly kind of in the physical therapy realm. But I know with ours, we have an accrediting board. And we also, with ours, of course, that most of the curriculums here, on average, not all of them, but many of them, they tailor their curriculum around kind of the recommendations from the accreditation board, but also from the national licensing exam, because a lot of the schools want their students to pass the first time because that's really looks good in the eyes of the board, but also it's kind of also partially how they get their money. And kind of my follow-up to that one overall is, are there any governing boards kind of within, medical education that kind of have control or say in that in any way, shape, or form?
There's several. The most important one for undergraduate medical education, so for MD training, is the LCME, the Liaison Committee for Medical Education. And, they set the rules, and they come and accredited organizations to make sure that you're following the rules. I think there's more flexibility in their system than folks realize, but they get so nervous about the LCME that for some of them reduces their willingness to take risk. There's a similar organization that accredits residency programs, ACGME, and it also makes folks nervous about what they can do, and in fact does enforce a lot of the status quo. So those are two, and then just as you mentioned, the board exams too really reinforce status quo learning. They try to evolve, and they have evolved, but they force a sort of focus on things that can be evaluated in multiple choice testing, and that is extremely limiting.
Yeah, no, I agree completely. And Clay, kind of going back, because I know you mentioned some of the limitations, and I think I agree with a lot of them. So I guess my follow-up question to that is, what can medical students, practicing physicians, and medical educators do to really help contribute to these issues to kind of help make it better?
Right now, the system, we're all physician morale is lower than it's ever been. And there are a variety of reasons why that's probably the case. But we need to be the ones that work with our colleagues and teams to find those solutions and to push them forward. And that's true whether it's medical students, practicing physicians, educators. But it's not just us; it's you guys too, right? This is the same system that you're in. And it's many others. And I think we've let the fee-for-service system kind of beat us all into the ground. And we need to be the ones to find the solutions, not wait for others to define them for us.
Yeah, Clay, I love that take on it. I mean, we really have to be proactive no matter what field we're in. If we're going to look to make medicine better, we definitely need to take the reins and take charge. And I'm glad to see a lot of people recognizing that and finally starting to dig their heels in and do the work. We like to end each episode with this last question to each of our guests. If you could change one aspect of healthcare education, whether it be medical or other healthcare provider related, which aspect would you change and how would you change it?
Favorite one is actually the board exam, to make the board exams pass fail. So, but it sounds like that has been taken. So I'll give you another one. We didn't really talk about residency education, and residency education has not changed much at all in many years since it's been going on, and that to me is another area that we need to really examine. And I think what's the change that's necessary? I think we need more flexibility in defining what the curriculum and the competencies should be for the residents, regardless of specialty.
Interesting. No, I think that's an interesting take on that, Clay. And, kind of one more to kind of follow up kind of with what you said before, kind of about the board exam and making it pass fail. Do you feel like there's been any motion to do that or work towards that's actually going to make that a reality at any point in the near future, or not really?
Well, I mean, there's some push to think differently about residency programs, including from the ACGME, which has sponsored groups to think differently about it. The AMA and the AAMC are also pushing that agenda. So, I think it's nice that when the sort of the bodies that are considered the most conservative are blamed for blocking change are actually promoting change. So it may be that we need to push them and to show what's possible, and that all of us then can be liberated to move things around, to move things forward more quickly.
That's awesome, Clay. I think that's a really good take. And, thank you so much for, this great content today, because I definitely learned a couple new things regards to the program, but also about medical education. And I think what you and your team are working on to do is really a really good step in the right direction. And I really applaud you guys for what you guys are doing, because I think we need more of this on a national basis. So first and foremost, thank you for that. But also thank you for coming on this evening to kind of share this insight with our listeners, because I'm really thinking this is going to be some really good stuff for them. And, and Clay, if someone's got questions for you kind of regarding Dell or anything, where can people find you online and on social media?
Yeah, so I'm on Twitter at Clay Dell Med, short for Dell Medical School. And yeah, that's probably the easiest way to reach me.
Very cool. Well, thank you again so much, Clay. It's always a pleasure.
My pleasure. All right, take care.
Thank you for attending class today, and we hope that you learned something and gained value from the content.
If you'd like to schedule office hours with us, feel free to add us on Twitter at HET Podcast, on Instagram, HET Podcast, on Facebook, the Healthcare Education Transformation Podcast, and the homepage, healthcareeducationtransformationpodcast.com.
And for those of you following along in the syllabus, extra credit can be obtained by liking us, sharing us, and leaving a review.
Let's continue our journey up Mount Educational Success as lifelong learners.